Hey guys, welcome back to my channel, The ENT Resident. Today our topic of discussion is a disease in the ear known as Malignant Otitis Externa. You can also now purchase my notes if you want, and I've added links in the description for that. Let's get started. So, how do we define Malignant Otitis Externa? This is an invasive bacterial infection of the EAC, which is the external auditory canal, and the skull base. And this usually involves and spreads to involve soft tissues as well. And this is usually seen in long-standing diabetics or immunocompromised patients. So, malignant otitis externa is basically an invasive bacterial infection of the external auditory canal and skull base, which spreads to involve the soft tissue and is usually seen in long-standing diabetics or immunocompromised patients. Now, why is this disease called malignant even though this is actually not a tumor? It is called malignant because of three reasons. The first one is that it has a very aggressive clinical behavior. Secondly, even though there are a lot of treatment for it, it has very poor treatment outcomes to it. And thirdly, it has a very high mortality rate. So these three reasons are the reasons why this disease is also known as malignant otitis externa, even though it is not actually a tumor of the ear. And there are a few other names by which it is also known as. The first one is skull base osteomyelitis, and the second one is necrotizing otitis externa. So this is about what malignant otitis externa is. Now let's move on to understand the pathology of the disease. How does this disease usually start? The mode of entry usually is, first of all, there is a self-inflicted trauma to the external auditory canal. And following this, the patient develops a pseudomonas infection. This is how the disease starts. Now, after the pseudomonas infection starts, it progresses very quickly. So this disease is basically the end stage of a very severe infection of the external auditory canal. And this starts spreading through any congenital defects it might find in the floor of the external auditory canal, like the fissures of Santorini. And this leads to formation of cellulitis, chondritis, periostitis, and osteitis. So you can see that there is a lot of inflammation going on due to this disease. And this spread happens via the Haversian system of compact bone, forming multiple tiny abscesses and sequestra of necrotic bone everywhere. And as the disease progresses, it leads to osteomyelitis. And once the osteomyelitis develops, this is followed by a very rapid spread to all the surrounding tissues, which can involve not only the soft tissues, but also it can extend into the skull bone and result in cranial nerve involvements, which leads to cranial nerve palsy, and there can be even other complications involving the brain tissue. Now, why is pseudomonas so invasive in this disease? So what happens in this disease is that pseudomonas has a very vasculitic property, and this vasculitic property of pseudomonas is responsible for the invasive nature of the disease. And this happens because of its ability to secrete exotoxin and even some other various enzymes like lecithinase, lipase, esterase, and protease. Also, pseudomonas has a coating of a mucoid layer, which kind of makes it resistant to digestion by macrophages. All of these reasons together combined leads to the invasive nature of pseudomonal infection in this disease. So this is about the pathology. Now let's understand what are the causative organisms other than Pseudomonas aeruginosa, and what are the predisposing conditions or risk factors involved over here. First of all, this disease is very common in old age. Second, the very important factor over here is the patient usually is seen to have uncontrolled diabetes mellitus. And why is this important over here? Now, diabetes mellitus is actually a microvascular disease. So this, combined with the vasculitic property of Pseudomonas aeruginosa, this leads to an aggravation of the vasculitis that is happening, and this restricts the tissue perfusion. And this is the reason why a combination of uncontrolled diabetes mellitus and Pseudomonas infection leads to such a invasive disease. Secondly, other than diabetes mellitus, the patient can also have any other immunocompromised state of the body. There can be any kind of immunodeficiencies and etc. Other than that, there can also be a malignancy of the temporal bone, and there can be AIDS, and there can be histiocytosis. So these are all the predisposing conditions to developing malignant otitis externa. Now, other than Pseudomonas aeruginosa, what are other causative organisms are there? So if we had to know that, the other organisms are Staphylococcus aureus. There can even be some fungal infections involved here like Aspergillus or Candida. However, the fungal cause is very, very rare over here. So this was all about the predisposing conditions and the causative organisms involved over here. Now, let's discuss what are the clinical features that you see in the disease. Very important factor over here is, first, usually the patient has a previous history of otitis externa that they present with. Second, they will complain of ear pain. This is a very important feature of the disease. Now, what kind of ear pain do they experience? First of all, it is a very intense ear pain, which is usually way more than expected in a routine otitis externa. It gets worse at night, so this is a nocturnal kind of ear pain, and it is resistant to any kind of local treatment given over a period of 1 to 2 weeks. This pain is constant and very deep-seated. So these are the features of the ear pain that the patient comes to you with. It is a very intense ear pain exceeding that of a normal otitis externa case. It is a pain that gets worse at night. It is resistant to local treatment, and it is a constant deep-seated nocturnal pain. Now the next complaint is that of ear discharge. If you see in the image over here, you can see the ear discharge, which is usually purulent in nature. And when this gets foul smelling, you will understand that the process of osteomyelitis has already started. Next, this disease can spread to involve the surrounding soft tissues of the cervical region and even the parotid region, and that can lead to a swelling in the parotid area. Other than this, as I said, there can be a lot of cranial nerve involvement. So the cranial nerves that can get involved over here are the 5th and 6th cranial nerve. If the petrous apex gets involved, and it can also lead to involvement of the 7th cranial nerve if the stylomastoid foramen gets involved, and it can get if it reaches the jugular foramen in the skull base, it will lead to the 9th, 10th, 11th and the 12th cranial nerve involvement. So as you can see, it can lead to multiple cranial nerve involvement over here. Next, let's discuss what are the signs you will be seeing on examination of the patient. So this is the right-sided image that you see over here. This is an image of the external auditory canal of a malignant otitis externa case. As you can see over here, the EAC is edematous, narrow and obliterated. There can be some sagging of the canal wall, but that is not necessary. You can also find some ear discharge, which is initially mucopurulent and blood-stained in the later stages. But however, the hallmark feature over here that clinches the diagnosis is you will find granulation tissue at the bony cartilaginous junction of the EAC. This is a very, very important feature which is the hallmark of skull-based osteomyelitis. You can see in the image over here, this is the granulation tissue which develops at the bony cartilaginous junction of the external auditory canal. Now this happens because of osteitis of the lateral lip of the tympanic bone. Other than the granulation tissue, you will also see that around this area there will also be a presence of some necrotic pockets. So this is all about the clinical features that you see in this disease. The hallmark feature is the most important feature to remember over here, which is the granulation tissue at the bony cartilaginous junction of the external auditory canal. Now, next let's talk about staging of the disease. How do we stage the disease? There are 4 stages of the disease, and this is something very easy to remember. The first stage is when you see all clinical evidence of the disease with infection of the soft tissue beyond the external auditory canal. However, you see that there is a negative technetium 99 bone scan. That is the first stage of the disease. Stage 2 is when there is infection of soft tissue beyond the external auditory canal, but in this time you'll find a positive technetium 99 bone scan. Next is third stage, when you find the soft tissue infection beyond external auditory canal with a positive technetium bone scan, but over here what gets added is a cranial nerve paralysis. Now this is further divided into stage 3A and 3B based on whether a single cranial nerve is involved or multiple cranial nerve is involved. And stage 4 is when it leads to complications of the disease involving the brain tissue, which leads to meningitis, empyema, sinus thrombosis, or even brain abscess. So these are the 4 stages of the disease that you need to remember. Next, let's talk about the spread of the disease. Now, the spread of the disease happens in every direction, and it involves all the bones and soft tissues around it. If it spreads anteriorly, it involves the temporomandibular joint and the parotid gland, so it can lead to a parotid swelling. When it goes posteriorly, it can involve the mastoid, and it can also involve the stylomastoid foramen, in which case you see a facial nerve palsy because facial nerve exits the temporal bone through the stylomastoid foramen. Next, if it progresses inferiorly, it can proceed onto the parapharyngeal space. Secondly, it can also go to the skull base and involve the jugular foramen, in which case you find a 9th, 10th, 11th and 12th cranial nerve palsies. Next, if it goes more medially, it can involve the petrous apex, at which case you find a 5th and a 6th cranial nerve palsy because these are the cranial nerves which pass through the petrous apex. It can also involve the middle ear medially and reach into the clivus and the contralateral temporal bone. By this stage, it is a very, very extensive stage of the disease. Other than this, it can also involve central venous sinuses, extradural space and meninges and lead to formation of brain abscess, meningitis, sinus thrombosis. So this is about the spread of malignant otitis externa. Now coming to diagnosis, as I have already mentioned from everything, this is actually a very easy clinical diagnosis. And what are the features which will all add up when the patient gives you a history and you have seen some clinical examination, you have seen symptoms and signs in the patient. Now, what are the factors which will clinch the diagnosis? The patient will typically be an elderly diabetic patient. They'll come to you with a severe otalgia, which is mostly nocturnal in nature. And they will present with a granulation tissue in the external auditory canal at the bony cartilaginous junction. When all of these features combined comes to you, it raises a very high suspicion that this could possibly be a skull-based osteomyelitis. Now that we have done some diagnosis, we have to also confirm our diagnosis. So for that, we have to hold certain investigations. Now, what are the investigations that we do over here? First of all, in basic blood examination, we will see that the ESR and CRP will be elevated. Second, we do a biopsy to rule out any kind of malignancy of the external auditory canal. Third, we perform a CT scan. Now, as we know that CT scan is very important to see the extent of bony involvement, whereas we do MRI to see more soft tissue involvement. So the CT scan will show you a diffuse soft tissue mass which is filling up the external auditory canal, and you'll also see some bony erosion. So if you see in the image over here, this is a CT scan of the disease where we are able to see bony erosion and there is a mass which is filling up the external auditory canal. Next is the MRI. Now, what is the importance of MRI in this disease? We do an MRI to find out what is the extent of soft tissue involvement, and this is usually done in more intracranial complications. So, we can do a MR venography when the jugular vein invasion is suspected, and we can do a MR angiography when internal carotid artery invasion is suspected. Next comes the Gallium 67 scan. Now, what is this Gallium 67 scan? This is very, very important in following up the patient while they are undergoing treatment. So what happens here is Gallium 67 is a compound which gets taken up by monocytes and reticuloendothelial cells. And this indicates soft tissue infection. So what happens here, in the soft tissues where the infection is going on, there are areas of actively dividing WBC, and Gallium 67 scan is basically able to show up those areas as hotspots, and this is what helps to monitor the resolution of infections, and we keep watching for fading of these residual hotspots. If you see in the image over here, this is actually a hotspot of the soft tissue involved over here. So this scan is very important because it will help you in tracking the progress and in tracking the response of the patient to the treatment being given to him. The scan is also seen to very quickly return to normal after the infection has resolved. So it is a very, very good indicator to measure the response to treatment and to terminate treatment. So this scan should be repeated every 3 weeks to monitor the response of the patient. So Gallium 67 scan is basically not for diagnosis, but rather to see the response of the patient to the treatment being given. The next one is a Technetium 99 bone scan. Now, what is the purpose of this scan? Technetium 99 is a compound which gets taken up by osteoclasts and osteoblasts. So it will end up showing up as hotspots within 1 to 2 days of the start of osteomyelitis. Hence, it is a very important indicator for early diagnosis of the disease. So Technetium 99 bone scan is basically showing the bone infection that starts. However, even though this is important in clenching an early diagnosis of the disease, it is not important to see the response of treatment of the patient because this scan remains positive for a year. So it is absolutely not a good indicator for resolution of the disease. And why does it stay positive? It stays positive as long as the bone repair continues to happen, which can actually happen for a long time post-treatment. So this scan is only done for early diagnosis of the disease. Lastly, there's another third scan known as the Indium 111 scan. Indium 111 scan is also this is also a leukocyte scan which can be supplemented along with the gallium scan, and this is more specific in the inflammatory process. So these are all the investigations that you need to perform in a case of malignant otitis externa. Now let's discuss the treatment. First of all, important is to understand what is the predisposing condition that has led to the disease. If it is uncontrolled diabetes mellitus, in that case first you have to control the disease, or if there is any other immunodeficiency state or any malignancy or AIDS, first you have to control the underlying disorder. Second is oral toileting. So because the disease is characterized by a lot of purulent ear discharge and also a lot of debris, granulation tissue and bone fragments in the external auditory canal. So daily meticulous cleaning and local debridement is very important to remove all of these debris, discharge and granulation tissue and even any dead tissue or bone that you find. Third, the mainstay of treatment is antibiotics. Now, antibiotics are usually used for about 6 to 8 weeks. And what antibiotics are given? The first group of antibiotics are the quinolones. Amongst quinolones, ciprofloxacin, ofloxacin, levofloxacin can be given orally. Second are the third generation cephalosporins. These can include ceftriaxone and ceftazidime, and usually this is combined with aminoglycosides. And thirdly, we have gentamicin, which is combined with ticarcillin, and this is usually given IV. So these are the three groups of antibiotics that are usually given. However, if the patient is not responding to any of this, in that case, you should actually send the pus for culture and sensitivity and find out which antibiotic is the patient sensitive to, is the disease sensitive to. In the off chance that the disease is actually caused by a fungus, in that case, amphotericin B is actually the most common antifungal used in treatment of skull-based osteomyelitis. Next, we come to analgesics. Now, the use of analgesics is very important here because one of the presenting features over here is the severe intense otalgia, which is felt more in the night time. The common analgesic used over here is acetaminophen. Next, we come on to hyperbaric oxygen therapy. Now, hyperbaric oxygen therapy has three modes of action by which it works. First, what it does is it increases the ability of the polymorphonuclear cells to able to fend off the pathogenic bacteria, and it increases the antibacterial effectiveness of antibiotics which we give. Second, it increases the oxygen levels which is carried in the blood. So all the hypoxic tissue which has been devoid of oxygen, it starts to return to normal oxygen tension. And third mechanism of action over here is it promotes the laying of collagen and angiogenesis, which leads to promoting the soft tissue and bone healing. So these are the three modes of action by which hyperbaric oxygen therapy helps in a case of malignant otitis externa. Now, what are the exact settings which are used? A pressure of 2.4 ATA for 70 to 80 minutes is given. And this usually comprises of 3 periods of 20 minutes of 100% oxygen. This is about hyperbaric oxygen therapy. Last of all, treatment option is surgery. Now, surgery is usually best avoided in these cases because in surgery what happens is even the healthy bone tissue gets exposed to further infection, and this can actually lead to worsening of the disease process. This surgery is rarely required in these cases, but however, it can be done when infection progresses despite the most aggressive medical treatment being given. So what surgery do we do here? We usually only debride the necrotic bone and the granulation tissue and drain out all the abscesses that you see. So these are the 6 treatment options that you use in case of a malignant otitis externa. Now we have to see how do we check response to the treatment, to the medical treatment that you're given. How do you know that the patient is improving? So the earliest sign that you see is there is a decrease in the nocturnal ear pain that the patient had initially come to you with. This is the earliest sign of progress, earliest sign of response to the medical treatment. And what is the earliest investigation response that you see is there is a drop in CSR and there is a drop in ESR and CRP of the patient, which is the inflammatory markers. And as I've already mentioned, the scan which is used to monitor treatment is the Gallium 67 scan. And this scan is repeated every 3 weeks to see the response to the treatment. Next, coming to prognosis of the patient. Prognosis of these patients is actually very poor even with all the massive antibiotics being used because these patients land up in septicemia, skull-base osteomyelitis and sinus thrombosis. And when cranial nerve palsies happen, it's actually an indicator of further poor prognosis except in the involvement of the 7th cranial nerve. And recurrence is also seen to be very common in this disease, and this can happen it can happen actually due to inadequate therapy, and this manifests as recurrent headaches and notalgia and never seen as a case of otorrhea. Last of all, let's discuss a little bit of complications and what are the differential diagnoses of the disease. Coming to complications, it can involve the cavernous sinuses in the skull, and it can lead to sigmoid sinus thrombosis. It can even lead to internal carotid artery thrombosis, and it can involve the brain tissue and lead to meningitis and brain abscess. Some common differential diagnoses of these patients are external auditory canal malignancy, granulomatous diseases, Paget's disease, nasopharyngeal malignancy, clival lesions, and fibrous dysplasia. So this is all you need to know about malignant otitis externa. If you have any further questions on it, please note them down in the comment section and I'll get back to you. Thank you.